All right, thank you all so much for joining us this morning. As Brian said, today we're going to be discussing the Kashi Health Weight Management Panel and hopefully help you all to better understand its utilization in the clinic and give you the opportunity to ask any questions you have about its use with your patients. Before we get started on that, I'd like to talk a little bit about Kashi Labs itself. Kashi Clinical Laboratories was founded in 2006 by our director, Dr. Zara Kashi. It was founded with the desire to meet the unmet need of accessible HLA testing in the transplant community. And after many years of success in this endeavor, Dr. Kashi decided to branch out into a more clinical avenue and developed Kashi Health. In 2012, Kashi Health was founded to address the clinical aspect of genetic testing, and over this time period, we've branched out to serve providers across the United States and internationally. We are CLIA and ASHI certified, New York and California state certified, and we operate with the goal to provide the most scientifically rigorous testing available to our clinicians. So today I'd like you to be able to walk away with a better understanding of how to utilize the Kashi Health Weight Management Panel in your practice, to have a better understanding of the actual markers in the Kashi Health Weight Management Panel and how to implement it in your practice, and of course address any questions you may have about specific patient care. So obesity. Obviously this is more than a cosmetic issue. At this time, more than 1/3 of the adults and 17% of children and adolescents in the United States are classified as obese. The health-related costs estimated with carrying this level of obesity is of roughly $147 billion. And this is accumulation of the various different health effects of obesity, considering dyslipidemia, insulin imbalance resulting in metabolic syndrome, type 2 diabetes, cardiovascular disease, joint disorders, hormonal dysregulation, etc. So helping our patients to better address their obesity and address their weight management issues is really a very arching concern. Largely, obesity is classified based on the body mass index. Obesity is defined as a body mass index of 30 or above, and while there is some limitations to body mass index, it is a very reliable way to gauge body fat percentage based on a simple in-office or at-home weight to height comparison. There is some variability based on ethnicity and percent of muscle mass that your individual patients may carry, so it may be a better measure of true risk when you couple the body mass index with a waist circumference, a waist to hip ratio, or if you have the tools at your disposal, body fat percentage, to truly gauge their obesity state. However, BMI is still the international standard for recognizing obesity. And as we can see in the next two diagrams, that obesity is really reaching a very high level across the globe. In our particular region, the United States has 33.3% or 1/3 of its male population classified as obese. But as you can see, this entire region is still suffering from a very high obesity rate. When looking at females, we may drop to number 4 in the region, but the actual percentage of females who are classified as obese has risen to 35.8%. So in 2008, worldwide, 1.4 billion individuals were classified as overweight or obese. So by looking at our BMI, studies have been performed to correlate elevated BMI and overall mortality risk. In 2009, Whitlock and colleagues published in The Lancet a study that compared BMI and overall mortality risk based upon 900,000 adults. What they had found is that roughly a BMI of 22.5 to 25 incurred the lowest mortality risk. And for every 5 BMI points that you went up above 25, you had a significantly higher risk of mortality. 30% for overall mortality, 40% for cardiovascular mortality, 60 to 120% for diabetic-related mortality, and the list goes on. We see a slight uptick as we go beneath 22.5, but that's largely associated with respiratory illnesses. So what our goal is in helping our patients to address their overweight and obese status is to help them to achieve a normal weight BMI in a zone that is going to be more compatible with reduced mortality risk. In 2001, when faced with the rising rates of overweight and obesity, the Surgeon General put out a call to action to physicians to prevent and decrease overweight and obesity. In this guideline, he explicitly states, overweight and obesity are caused by many factors. For each individual, body weight is determined by a combination of genetic, metabolic, behavioral, environmental, cultural, and socioeconomic influences. Some of these factors we can control, some of them we cannot. But in many cases, the metabolic, behavioral, and environmental, we are working with our patients through various lab testing and lifestyle changes to be able to address weight management concerns. But what about the genetics? This large portion of our risk towards obesity in many ways is going unaddressed, and those needs are being unmet. Many factors contribute to obesity risk. Resting metabolic rate, how the body responds to macronutrients, our activity level, how we perceive our hunger or a satiation, how we're able to regulate how much our food is consumed, hormonal regulation, both through the steroid hormones and the neuropeptides involved in hunger level. But of course, we have genetic susceptibility. Depending upon ethnicity, the genetic contribution to obesity can range anywhere from 40 to 86%. This large contribution to obesity risk in many cases is not being tested for and is not being counseled to our patients. So through testing with the Kashi Health Panel, you can get a better understanding of what your patient's genetic risk is and then counsel them to better structure their diet plans. To take it to just the basic regulation level of obesity, we have to look at the hypothalamus. Regions in the hypothalamus regulate how we are perceiving hunger, which dictates our calorie intake, how we regulate our metabolism through energy expenditure and glucose and fat metabolism. This region is largely regulated by the melanocortin system, which is broken into two neuronal sets. We have the NPY neurons, which release peptides that are designed to increase the perception of hunger, and the POMC neurons, which secrete peptides which are designed to decrease hunger. These two regions directly communicate with one another and work to inhibit and express each other in a cooperative fashion and are acted on by key mediators leptin, ghrelin, and insulin. Leptin is one of our key peptides involved in decreasing hunger. Leptin is produced largely by the white adipose tissue and travels to the hypothalamic receptors in the brain to help to decrease hunger by cueing the POMC neurons to release satiation peptides. So it would hold that as adipose tissue increases, and we increase the amount of leptin that is produced by the body, then we should experience a decreased appetite and an increased metabolism. However, that's not always the case. Obese individuals, by and large, do tend to have a higher circulating leptin concentration, yet they do not experience this perceived level of satiation. What's occurring here is something referred to as leptin resistance. There's a few different theories as to what causes leptin resistance, but ultimately it boils down to an inability for the hypothalamus to properly receive the signals that leptin is communicating to reduce hunger levels. Ghrelin, one of our other hormones, is secreted by the gut. It's produced in the stomach when the stomach is empty, and when the stomach is full and the individual has filled their stomach with food, the stretch receptors in the fundus of the stomach suppress the secretion of ghrelin. When the stomach is empty and ghrelin is circulating, the patient perceives a higher level of hunger. When the stretch receptors are activated and the ghrelin is suppressed, that hunger cue is supposed to go away. The ghrelin is also strongly correlated with the islet cells of the pancreas, where when we have higher ghrelin levels, we exhibit lower insulin levels, and when we have lower ghrelin levels, we have higher insulin levels, which makes sense considering lower ghrelin is associated with having consumed food, and thus the glucose in the bloodstream should be a cue to increase insulin. And higher glucose levels can help to decrease ghrelin levels. Insulin, of course, plays a key role in weight management, as we see in situations like metabolic syndrome, type 2 diabetes, things of this nature, and they fluctuate with alterations in blood glucose level. These fluctuations can trigger various different food cues, and insulin, as it is circulating through the body, also interacts with the various neurons in the hypothalamus to help to regulate peripheral fat and glucose metabolism. All three of these hormones work in concert with one another and help to inhibit and express the peptides secreted in the hypothalamus in a very commensurable way. They work on many of the same pathways, and unfortunately that gives to the fact that when some of them become dysregulated, others also can become dysregulated in a parallel fashion. Many of our patients are going to try to control their weight through various different diets. In 2011, the weight loss industry was estimated at roughly $60 billion. And in any given year, anywhere from 1/3 to 1/2 of the individuals in the United States will attempt some form of weight reduction diet, many of them without great success. Many of the diets are medically necessary, such as like a DASH diet in a hypertensive patient or a gluten-free diet in a celiac patient. Some of them are going to be fad diets, such as the cabbage soup diet. What we have seen is that patients that have greater success in holding to their weight management plan for a longer period of time have greater success in maintaining their weight loss after they have reached their weight loss goals. We've also seen that patients that follow a doctor-supervised or a doctor-recommended diet have greater success because they feel that the diet is more reliable. However, there's so much information out there about the fact that obesity is an issue. Obesity carries health risks. The obesity trends are increasing, and there's all of these diets in order to help you lose weight, so how come weight loss isn't more successful? Part of that has to do with poor compliance on the patient's part because they have frustration and give up on their various dieting plans. Some of it is they're just not quite sure with all of the various different types of diet plans out there which one they should be choosing, and some of them are just going to have guilt about the fact that they don't understand why they still feel hungry and those around them don't, and why they work so hard to lose weight and those around them don't. And so with this, we can really help them to better understand how to direct their diet and how to mitigate some of that guilt to get better success. What we're offering is an ability to cut through the confusion of all the various different diet plans and all the various different recommendations out there to help your patients get better success. All of us are exposed to the same obesogenic environment where we have a prevalence of convenient, nutrient-poor foods and a sedentary lifestyle. So how come we aren't all losing weight? How come we aren't all experiencing obesity? What we're offering is the ability to really zero in and offer your patients something that is going to work for them. So how does this genetic testing fit in? Well, In 2005, we started to develop a process of looking at genes called a genome-wide association study, also referred to as a GWAS. What they've done is they've taken a hypothesis-free approach that allows analysis of a large sample size of multiple unrelated individuals based upon a single symptom. In our situation, this symptom is obesity. The first GWAS began looking at obesity and found a correlation with the marker FTO. Shortly thereafter, additional GWASs were performed that confirmed the association of FTO with obesity and identified other markers such as MC4R and all of the other markers that you're seeing here. With this, we're able to get a better understanding across various ethnicities what variants in the genetic code are going to lend a contribution to obesity. So with that, we have culled the literature and found what we find to be the most reliable genes and directed our panel and protocol accordingly. The criteria for marker selection included a reported connection with body mass index in a nationally recognized peer-reviewed journal, an established connection with metabolism, fat storage, nutrient absorption, or another physiologically important affiliation with weight management. The variance allele, or single nucleotide polymorphism, also referred to as a SNP, of each marker must be present in at least 10% of the population or is associated with a medical implication that has been well established by the scientific community. All of the markers in the Kashi Health Weight Management Panel have reached at least a 10%, many of them well above 10% prevalence in the population. And finally, the evidence of the marker must be associated with a health outcome in multiple publications and in individuals of varying ethnicities. So many of us are aware of what a SNP is, but just to make sure we're all on the same page, a single nucleotide polymorphism is a point mutation where we have what we would expect to see in the gene and the change in the gene. There are hundreds of thousands of SNPs throughout the human genome, and a lot of them infer no risk whatsoever. What we're looking for is SNPs that infer a specific risk towards BMI, obesity, weight gain, or other criteria previously mentioned. The way we've set forth to design the Kashi Health Weight Management Panel, it helps your patients to guide diet selection based upon recommendations found in the literature, provide macronutrient ratios to get the best weight results possible, physical activity recommendations, and behavioral cues that affect success, such as understanding the ability to perceive satiation, how well your body responds to physical activity, etc. The markers that we utilize in the Kashi Health Weight Management Panel include 5 different markers: FTO, the human fat mass and obesity gene; MC4R, the melanocortin-4 receptor; FABP2, the fat binding protein; ADRB2, beta-2 adrenergic receptor; and SH2B1, a circumology-2 adapter protein. But hands down, FTO is probably one of the best studied markers associated with weight management. FTO is located throughout the body, but largely is expressed throughout the hypothalamus. Discovered in the first GWAS put forward in 2007 by Frayling and colleagues, the results of the study found that the variant allele caused more of the FTO gene to be expressed. This higher level of expression is strongly associated with increased BMI and energy intake, i.e. calories. The effect of the variant causes each copy of the risk allele to confer additional obesity risk. Therefore, if you have one of the risk allele, you will see an elevation in your weight or BMI. If you have 2 copies, you will see a double elevation in your weight or BMI. Obesity risk increases in individuals that have a high-fat diet, particularly if that fat is saturated fat. And higher levels of physical activity can help to reduce the effects of the risk allele. These individuals also respond favorably to a high-protein diet and a Mediterranean diet, as both are shown to modulate the effects of the risk allele. What is suspected with the FTO variant is that the body is having a failure to suppress ghrelin, so the body is not properly getting the cessation of that hunger cue. So this causes the body, the patient, to continually feel hunger, to then experience an increased calorie intake and a preference for calorie-dense foods. Recently, a study by Rosenquist was put out that explored FTO and birth year. What this looked at is they took participants of the Framingham Heart Study and the offspring cohort and broke them into groups based upon the year that they were born. Then they compared it to if the individuals carried the FTO risk allele. What they found was that individuals born after 1942 who also carried the FTO risk allele had the highest BMI compared to other participants. What this shows is a wonderful example of how the environment that an individual resides in can affect how the phenotype is being expressed. The investigators put forth that this increase in BMI was largely attributed to a change in a labor-based workforce to a more sedentary workforce and a higher prevalence of convenience foods and moving away from the nutrient-rich foods that we were consuming prior to that. However, the one thing that must be noted is that individuals that didn't carry the risk allele didn't have as elevated of a weight gain as individuals who did. So while we all still live in this more sedentary lifestyle with poorer food choices, people who do carry the allele are more vulnerable to the weight risks that our lifestyle now entails. What we've put forth for the FTO diet plan is a modified Mediterranean diet, a low-fat Mediterranean diet. Studies have shown that the Mediterranean diet has proven to give favorable results in FTO carriers in weight loss reduction. However, with taking into consideration that FTO carriers also have a tendency towards weight gain with higher fat diets, we're recommending a reduction in fat with an emphasis on unsaturated fatty acids over saturated fatty acids. And also emphasis on protein to be able to release more of the satiation hormones that the body produces in the lower gut, and more fibrous carbohydrates to really maximize on the ghrelin suppression through the stretch receptors of the stomach. Excuse me. We also are recommending frequent small meals, as this has shown that participants that had more frequent meals had lower weights, and this also helps to circumvent any propensity towards snacking. Our next SNP, the MC4R, is a receptor located in the hypothalamus. It's part of the melanocortin pathway and is acted upon by a peptide formed in the POMC expressing neurons, the alpha MSH, the melanocyte stimulating hormone. In a properly acting MC4R, stimulation leads to suppression of appetite and a higher metabolic rate. And it is directly antagonized by the NPY, a neuron secreting a Gaudy-related protein. The SNP that we're looking at is located in a region near this gene. It's not quite understood why this has such a profound effect on obesity, but it is known that the gene itself carries a mutation that is linked to extreme childhood obesity. However, this SNP, even though it is near it, has a more subtle but still very pronounced effect on weight management. The effects of the MC4R mutation, these individuals are more likely to have poor regulation of food intake. They exhibit a higher propensity to snacking, a higher perception of hunger, higher total calorie intake, and higher fat and protein content. They're also associated with higher BMI. Each copy of the risk allele correlated to a 0.22 increase in BMI. The additive effects with FTO are also seen with this, whereas if an individual carries both the MC4R and the FTO, their BMI and tendency towards snack will be even higher. The MC4R is also associated with an increased waist circumference. What we've designed for the MC4R diet plan is similar but a little bit different to the FTO. What we're looking at here is a low energy density diet. So we're looking at low fat, high fiber to be able to again provide more volume to the stomach content to help activate stretch receptors to suppress ghrelin production. Frequent small meals also help to preemptively prevent overeating because of the increased tendency to snack. With these individuals, 5 or more small meals a day was associated with lower BMI and also circumvented the tendency to eat more frequently. It's also important that these individuals exercise 50 to 60 minutes daily because better weight loss is seen with the higher activity level. With sedentary or moderate to low activity level was more associated with obesity risk. That's something that on some level we understand because we all know that we need to exercise in order to lose weight, but these individuals again are just more vulnerable. Our next SNP, the ADRB2, is found on many different tissue types including the liver and fat cells. It is activated by catecholamines to release stored glucose in liver and muscle cells, to reduce gastric motility and increase insulin secretion and enhance fat oxidation in response to stress. The beta-2 receptor is the dominant lipolytic receptor in the white adipose tissue and is responsible, like I said, for fat oxidation. And the gene itself is associated with obesity susceptibility and asthma. The effects of the gene show a significant association with higher BMI and obesity, lack of physical activity and overeating make it easier to gain weight. For these individuals, it may take longer to achieve weight loss results through the lower level of fat oxidation after exercise, and weight gain is possible with excess carbohydrates from insulin resistance and higher triglyceride levels. These individuals also have a tendency to carry larger fat cells and a higher amount of fat mass. What we've designed for the ADRB2 diet plan is a lower carbohydrate diet, as it was shown that individuals who exceeded 49% of their daily calories in carbohydrates had a tendency towards greater weight gain and insulin levels. These individuals with the lower fat oxidation ability do need to maintain a higher level of activity. They may not respond to exercise as effectively as individuals who do not carry the risk allele, so this is something that needs to be counseled in the patients so again they don't lose motivation and feel well supported in their weight loss efforts. FABP2 is an intracellular protein located in the small intestine where it aids in dietary fat trafficking and absorption. The polymorphism involved in the FABP2 marker induces a conformational change where we have an increased binding affinity for long-chain saturated fatty acids and unsaturated fatty acids up to 2-fold. Greater levels of fat synthesis and chylomicron secretion are also exhibited in carriers of this allele. What we may see in people who carry this allele is a greater level of fat synthesis and chylomicron secretion and increased fasting glucose and lipid concentrations when consuming a high saturated fatty acid diet, which may impair insulin-stimulated glucose uptake by the cells. The FABP2 polymorphism is associated with a lower resting metabolic rate, higher amounts of abdominal fat, higher BMI, and prevalence of type 2 diabetes. What we've designed, because FABP2 has a tendency to increase fat uptake, is of course a low-fat diet with a preference towards unsaturated fatty acids as they are more readily packed into chylomicrons as opposed to saturated fatty acids which may be free in serum or travel to the liver, which can impede insulin health. Choose complex carbohydrates to support better insulin regulation, and increase physical activity, particularly before largest meals of the day, to reduce post-meal blood lipid levels, and with a recommendation to consider strength training. Strength training or anaerobic training has a greater effect on reducing the post-meal blood lipid levels as opposed to aerobic training and sedentary activity. Our final marker, SH2B1, is strongly associated with the insulin systems of the body. It's been identified as a positive regulator of insulin, IGF-1, and leptin, and is a docking protein involved in cellular signaling, particularly in insulin function. It's involved in the PI3K activation system of the body, which is largely associated with both insulin and leptin, and, well, for that matter, many different functions in the body. But for our purposes and how we look at it through a weight management lens, it helps to mediate insulin's metabolic functions. The effects of the SH2B1 polymorphism may control downstream leptin receptor signals. The polymorphism is associated with leptin resistance conferring a reduced ability to recognize fullness, insulin resistance, weight gain and obesity, elevated BMI, metabolic syndrome, type 2 diabetes, and a preference for calorically dense foods. What we've designed with the SH2B1 diet plan is our low glycemic diet. This helps to reduce the effects of both the insulin and the leptin resistance involved with SH2B1 carriers. We're also looking to control dietary fat to help to mediate the insulin effects and reduce saturated fat intake as it is opposed to greater obesity risk in these individuals. Again, we're looking at more frequent small meals, the 5 meals a day, to help limit portion sizes and to prevent overeating and inducing insulin spikes. So, with all of this, how do we utilize this with your patients? It's very reasonable to use this in a more traditional setting with these individuals looking at a CBC, CMP, thyroid panel, oral glucose, insulin, etc. It's very reasonable to get a full rounded picture of what their health situation is and then utilize these results to structure a personalized plan accordingly. This approach is going to be very useful in patients that have been resistant to weight loss efforts or have other risk factors for health disorders, particularly cardiovascular disorders, and may be useful in patients that may have a history of personal obesity or family history of obesity or obesity-related health issues. A potential patient that this profile would work well for would fit the following criteria: poor results from prior dietary changes, weight regain after loss, frequent cravings or tendency to overeat, a sedentary lifestyle, persistent weight gain, elevated BMI, or weight gain in the stomach, hips, and thighs. So, is all this genetic information going to help? There is concern among providers and lay people alike that patients will assume that because their weight issues are influenced by their genetics, that this is a predetermined state and they can't do anything about it. Well, we've already put forth that we've studied the literature and there are definite actions that can be taken to affect how the genotype is expressed. But studies have also shown that patients actually have a very high level of interest in this information. And patients with weight management issues show a higher motivation to change after receiving their results. There's a sense of relief and a reduction of guilt around having an explanation about why they're having issues with their body weight, and a propensity to adopt realistic expectations about how much weight should be lost and over what period of time, and more satisfaction when those goals are reached. There's also a higher motivation to change in patients that receive the results as part of a weight gain prevention, either in individuals that have already successfully lost weight or in individuals that have risk factors where weight gain would be very detrimental. Recently, the American Heart Association, the American College of Cardiologists, and the Obesity Society put forth guidelines for recommendations for weight management in adults to address the increasing overweight and obesity statistics facing our nation. In those guidelines, they recommended at annual visits to measure BMI and waist circumference, In individuals with cardiovascular risks, to advise a modest weight loss of 3 to 5% can reduce cardiovascular risk factors. Prescribing a reduced calorie diet based upon gender, prescribing a 500 or 750 calorie a day energy deficit, or to select from evidence-based diets to create the energy deficit through reduced food intake. What we've designed through our report tip-ins and our patient booklet is a report that provides tools to guide this entire process. In our sample report, you'll see we have a current snapshot of where your patient currently lies, their current weight, their current height, their current BMI. With that, we also put forth what a realistic goal weight would be for them to attain a normal weight goal BMI of 18.5 to 25. We also put forth a realistic time frame as to how long it would take for those individuals to lose that weight based upon 2 pounds lost per week all the way down to half a pound lost per week. This particular patient shows 2 variants. They show FTO actually has 2 copies of the risk allele, and for ADRB2 has 1 copy of the risk allele. In your report, you'll receive tip-ins that give recommendations as to how to now structure the diet and weight loss strategies for the diet for your patient based upon their results. Here, just some of the key points involved in the FTO allele. A lot of those we've already discussed about proper macronutrient choices, macronutrient ratios, how frequently to be consuming your meals. Same thing with the ADRB2. Recommendations of physical activity, how to structure your macronutrient ratios, and how to select the correct carbohydrate fatty acid choices. So what if your patient has more than 1 variant? This is very common. As we've seen, as individuals carry more than 1 variant, their risk for obesity increases, and patients with a higher level of obesity are tending to reach out for these tests. So how we handle the recommendations based upon individuals with more than 1 variant depends upon a couple factors. If they carry more than 1 allele in a particular gene, and how we're going to put those together. So this particular patient was homozygous for FTO, so it's slightly weighted to reflect the FTO more closely. So for this individual, the recommendations would be 45% carbohydrates, because that still pertains to the ADRB2 not having the insulin issues. 30 to 35% protein, as FTO carriers do better with a little bit more protein, and still 20 to 25% fat, as FTO carriers do not do well with a higher fat diet. In the booklet, we've also set forth many different guidelines to be able to give your patients all the tools that they need to walk out the door with a well-designed, well-educated plan. We put together explanations as to how many calories per gram are in the various macronutrients, how to choose the best choices for dietary success. We've also put together how to properly hydrate the body to support better weight loss with the ideal of half your body weight in ounces daily. Of course, if your patient has any cardiovascular or renal issues, this is something that you can modify appropriately. Recommendations on adequate sleep and reduction in alcohol, reduction in sugar, reduction in sodium, and of course stress management, as we all suffer from stress in our diet, but an individual trying to make a lifestyle change needs to be able to reward themselves in ways that does not involve food and keeps them striving towards that next milestone. We also, for the physical activity recommendations, have put together a guideline that the patients can use to help them understand how hard they're working. A lot of our recommendations are in the light to moderate realm, where hard to maximum is more for intervals. If your patient has any risk factors that this would be too aggressive for them, such as their beginner workout or they have any health issues where you'd have to be wary of elevated heart rate, there's ways to guide them through very light exercise as well. And finally, we have goals guidelines as to how to help to structure how many calories your patient should be bringing in a day. So based upon weight, these are calorie recommendations to maintain your weight based upon your activity level. So with this, you can go forward and make the appropriate recommendations towards the calorie deficits to help reduce weight. Through the various tip-ins and the personalized diet you receive with your reports template, through all of the information put forward into the patient booklet, we've designed something that we hope is very, very useful to you in helping your patients to achieve their overweight and obesity management goals. Just want to say thank you. I hope that that was very informative and helped to better understand all of the various different markers that we offer. I'd like to now open it up to any questions that you may have. And again, thank you for your time, and let you know that if you have any questions now or in the future, please feel free to reach out to myself or Brian, and we'll be more than happy to help you.
Yeah, thanks so much, Dr. Ferdinand. That was a wonderful presentation and very informative. If you guys do have questions, I invite you to go ahead and type them out now, if that makes sense for you. Otherwise, there's a little button on the side of your screen. It's on the bottom of the blue buttons. You can go ahead and raise your hand, and we'll just unmute your mic, and you can feel free to ask it now. So we'll just give you guys a few minutes to go ahead and gather your thoughts on that, and we'd be happy to be a resource for you now or later. So we'll just pause for a few seconds and see if anybody has any questions. Okay, everybody, it doesn't seem like there's any questions out there yet, but you could definitely have our email addresses there. So what we're going to do is we're going to go ahead and send you a copy of the slides for your reference. As you start using the weight management panel, you might have questions, and this will be a quick, easy reference for you. We've also been recording the webinar, so we'll also send a link out for that information here shortly. And you can use that as a reference. Feel free to watch it again. Of course, myself and Dr. Valerie are always here for a reference for you. If you should ever need anything, thank you all so much for being, for attending. We really appreciate it, and we're looking forward to doing many more of these to help you better understand and how to utilize our genetic testing. Thank you all so much, and have a wonderful day.